Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, it's always a pleasure to have John Scott doing a talk for us. I think most people know John. John is one of the leaders in telehealth and is also an assistant professor here in the Division of Infectious Disease. And I'll just turn it over to John.
Great, thanks, Brian. So I thought what we'd do today is actually go over a case. So if you can get ready to do a poll here, log in, and in a couple of slides, I'm going to ask you to vote on a case. So these are my disclosures. And so the objectives over the next 15 minutes is to discuss the pros and cons of treating hepatitis C now with some of these new exciting drugs versus waiting with even more exciting antivirals that are coming down the pipeline. And specifically, I wanted to talk about this issue of using cimeprevir and sofosbuvir. Those are two FDA-approved antivirals that are available, but if you look at the labeling, those are actually not approved to be used together, and a lot of people are doing that. So the case is a 55-year-old Caucasian man. He's co-infected with HIV and Hep C, and he comes to you wanting to know, hey, should I be treated for my hepatitis C? So specifics are that he was diagnosed in 1990 with his HIV, has a nadir CD4 count of 100. He's on antiretrovirals for the last 15 years and had really good adherence and suppression. He's currently on a pretty clean regimen of raltegravir plus Truvada, and his CD4 count is over 500, and his HIV is undetectable. In terms of his Hep C, he was diagnosed in 1995. He's never been treated for his hepatitis C. He has genotype 1A and a viral load of 1 million. And he's had a liver biopsy that shows F4. Okay, so that's cirrhosis. In terms of how his liver is doing, has good synthetic function. His INR is 1.1, Billy's normal, creatinine's normal, so that would put him a MELD score under 10. Platelets are 100, albumin 3.6. So he's never had any decompensation events like ascites or encephalopathy. And he's otherwise in pretty good shape. Doesn't have any diabetes, coronary disease, kidney issues, or significant psych issues. So I know this is not always the case that it's so clean like this, but for the sake of the discussion, I wanted to kind of take some of those other variables out of the picture. Get ready to vote. These are the treatment options. So the first option is to treat now with a 3-drug combo of interferon, ribavirin, and sofosbuvir for a total of 12 weeks. That's option A. Option B is to treat with sofosbuvir and cimeprevir for 12 weeks. Okay, so no interferon. Option C is to treat with sofosbuvir and cimeprevir and add ribavirin, and maybe tailor your therapy based on how they respond for anywhere from 12 to 24 weeks. Option D is to treat with sofosbuvir and ribavirin for 24 weeks. And then the last option is to wait for some other kind of non-interferon regimen, such as sofosbuvir or ledipasvir, that you think are going to come out in the next 12 months. Okay, so it seems like the majority of people said to treat now with PEG interferon, 57%. We had 14% try to go with the Simsof, and then about 20% of the folks said to wait for sofosbuvir and ledipasvir, and one person wanted to go with a little bit longer, more intensive course as Simsof. I personally don't think there's a right answer. It's more kind of to see where people are landing. And I'll just kind of give you my experience in our clinic, and kind of, I think more and more of us are waiting for some of these new regimens coming down the road in the next 4 to 6 months. That's kind of our general bias. I don't think there's a right answer, though. And part of that is just really getting back to the patient and having that conversation. So I just want to remind folks what the label is for sofosbuvir, and remind people that it is indicated for HIV-positive patients for genotypes 1 through 4, and even those with HCC and are awaiting liver transplant. So I think one of our cases today is in that category. I also wanted to pull out the quote that's on the package insert, is that if you have a patient for whatever reason is interferon ineligible or intolerant, there is this option of going with just sofosbuvir and ribavirin for a total of 24 weeks. In general, though, we want to go for 12 weeks with the PEG interferon for genotype 1s, 12 weeks with no interferon, just the ribavirin for genotype 2, and then we have to go a little bit longer for genotype 3, 24 weeks. So that certainly adds in the cost. So I just want to review the pivotal trial that was used for the FDA labeling. This is called the PHOTON study, and it was in genotypes 1, 2, 3. And these patients had to have stable HIV as indicated by a CT4 number 200 or be over 500 and not on antiretrovirals. They had 182 patients. So they had it in 3 different categories. The genotype 1 treatment naive, that's what TN stands for, and they received a total of 24 weeks of sofosbuvir and ribavirin. So no interferon, interestingly, in this study. And then genotype 2s and 3s who were treatment naive got a total of 12 weeks. Genotype 2, 3s who were treatment experienced got 24 weeks. And they had quite a range of antiretrovirals that were permitted, and they also had compensated cirrhotics in the study. So you can see that the genotype 1 patients, and this is without interferon, actually did very well, 75%. Genotype 2s did really well, whether they got 12 weeks or 24 weeks. And we've learned this from the HIV negative patients, is that you really need to go a little bit longer for the 3s. So that's why you need to go with 24 weeks. You get almost a 90% cure rate versus just about a 2 out of 3 chance if you go for 12 weeks. So next I want to go over the COSMOS study. This was a study of patients who were undergoing treatment with sofosbuvir and cimeprevir, and these are really tough to treat patients. There were 2 cohorts. The first cohort were patients with early fibrosis, so they were F0 to 2, and had completely negative or null response to prior interferon ribavirin. Cohort 2 was different in that they were F3 and 4, and some of those people were treatment naive, some were prior null responders. And if you just look at the patient characteristics, a lot of them were 1As and had this mutation called the Q80K, which is quite predictive of non-response to cimeprevir. So bear that in mind. A lot of these people had the bad IL-28 for treatment response. So this truly was a tough to treat cohort. There were 4 treatment arms. This is in cohort 1, same design though for cohort 2. They got either 24 weeks of the 3-drug combo, 24 weeks of the 2-drug soft sim combo, 12 weeks of the triple combo, or 12 weeks of the sim-soft combo. And what you can see here in the F0 to 2s is that the cure rate was pushing 90%. Just a little bit of explanation. What happened here in this first group, people got treated the longest with the most drugs. They had more people drop out with that because of side effects. And this was an intention to treat analysis. For the second cohort, again, the same design, just that they have worse fibrosis. And you see cure rates, again, over 90%, and even in one situation, 100% cure rate. Low, I just want to point out low numbers here, though, at most 15 to 30 patients per treatment arm. So a little bit of caveats about this study. Number 1, this is all HIV negative patients, okay? And cimeprevir is a protease inhibitor that has quite a number of drug interactions to the CYP3A4. So you definitely want to make sure that they're not going to have bad drug interactions with your HIV meds. And in particular, the protease inhibitors, the HIV protease inhibitors are often have a lot of drug interactions. This drug combo was not studied in decompensated cirrhotics. So if you have a decompensated cirrhotic, you probably want to either have that done in a liver transplant program or do it with extreme caution because cimeprevir is cleared by the liver. And we just don't have a whole lot of safety data. So I kind of want to give you an idea of when I talk about the future drug therapies, what am I talking about? And in summary, there are going to be 4 new drug combos in the next year, with 3 of those coming out in the next 6 months. The first one will be this drug called sofosbuvir plus ladipizvir. It's going to be 2 medicines rolled up in 1 pill, kind of like Truvada. And we expect that one by October 2014. The next regimen is from AbbVie. It's called the 3D combo, and that has 3 drugs in it. So it's an NS5A inhibitor plus a non-nucleoside inhibitor, dasubivir, and this other drug, it's a protease inhibitor, ABT450, plus ritonavir. And in some situations, you do need to use ribavirin. So this is a BID regimen that we expect to come out in November 2014 in the phase 3 trials, they saw cure rates around 95 to 99% cure rate with genotype 1 naive. So great, great cure rate. Then the other drug coming out in December will be a drug called decladisvir, an NS5A inhibitor, in conjunction with a drug called asaneprovir. And then probably in 2015, you'll see this combo from Merck, a really potent second-generation protease in conjunction with a NS5 inhibitor. So lots of things coming out. The only thing I would say in context HIV, I don't expect that any of these are going to get an HIV labeling, at least initially. Probably I'd expect another 6 to 12 months before any of these get an HIV labeling, with probably sofosbuvir, ladipizvir being the first to get that labeling. So let's talk about that sofosbuvir, ladipizvir. And these are the ION studies, ION 1, 2, and 3. They were published in the New England Journal, I think in the April, May issues. And I'm just going to talk about this one in which there were cirrhotics accepted, and they were treatment naive, like in our example, our patient example. A big number, 865 patients. And they were randomized to a variety of combinations, either ladipizvir for sofosbuvir for 12 weeks, ladipizvir sofosbuvir plus ribavirin for 12 weeks, the dual drug combo, ladipizvir sofosbuvir for 24 weeks, or the triple drug combination for 24 weeks. So pretty similar to what we were seeing in the Cosmos study, and a lot larger sample sizes, over 200 in each arm. And what you can see here is a 97 to 100% to 99% cure rate, which is pretty amazing. This is an intention to treat analysis, and my understanding is a lot of these people who were not cured in this, and some of these arms they just were lost to follow-up. Some of these people here who weren't cured rolled over to a longer treatment course, and all those people who rolled over subsequently got cured. So what about cirrhosis? And this is, again, would be relevant to our case example here. Didn't really seem to impact your cure rate, anywhere from 97 to 100%, regardless of whether you got 24 weeks, 12 weeks ribavirin or not. So I think what we're going to probably see is a label of 12 weeks of just ladipizvir sofosbuvir for our patients who are treatment naive. On the one hand, treating now, you've got an 80 to 90% chance of cure. We are seeing insurance paying for cirrhosis, patients have cirrhosis. And the major downside would be the side effects of interferon ribavirin, but with just 12 weeks, it's actually quite short, and we know how to manage those side effects pretty well. In terms of treating later, at least a 95% chance of cure, which we're seeing in the last studies, much better tolerated because you don't have interferon. And I still think that insurance is going to pay for it, especially for an advanced fibrotic. But I do want to let you know that the IDSA and AASLD guideline writing committee will be releasing their guidelines of when to treat in the next probably 4 weeks. And that will be posted on the web at www.hcvguidelines.org. So that might actually be a big driver of whether insurance is going to pay for this or not. So with that, maybe I can turn it over for questions.